and new guidances, and we will be talking about those. I see the chat is already lighting up with relevant questions, so I am excited that we can really get into this. And without further ado, I'll turn everything over to Dr. Randall Maxey, our founder. Dr. Maxey.
Good afternoon, everyone. It's my pleasure to be here with you, and I thank my stellar co-moderators, Dr. Barbara Nabert, Dr. Ivan Walks, and Dr. Hines, for continuing to join. As you know, we started Black Health Trust almost 2 years ago, if my memory serves me right, to combat all of the misinformation and fear that was there by bringing you what we call trusted messengers, physicians who have worked and are from our community of medical care. And a lot of us, if not most of us, are members of the National Medical Association. And we took the initial track of looking and studying the guidance of the National Medical Association and meeting and deciding that their guidance was correct by our own study. And this study resulted from talking with Pfizer, with CDC, with Moderna, and with experts with and without the walls of the NMA. And we have provided, I think, a plethora of and wealth of information over the past 2 years. Because we're a 501c3, we have stayed largely away from politics, at least in the Democrat-Republican side of things. But I think we must clearly look broader than just actual physical health and look at the things that affect our living in this country. And I was struck yesterday with the 4 unfortunate people who were held hostage in a synagogue in Texas, and by a so-called Islamic radical person. And it took only a few hours for a hostage rescue team of some 200 FBI agents to be dispatched to that church in freedom. To date, I've not had any information that when several thousand people stormed the Capitol, that any federal agency dispatched people to put that down. And that's not Democrat or Republican, but when people in this country decide they want to do something, they don't let anything stop them. So just hold that in mind as we look at the things that are affecting our communities. I submit that there's a lot of purpose behind the viral and bacterial attacks upon people of color. And in the context that when they want to get rid of this, it'll be attacked much more radically than it is now. But we want to discuss things of importance to this audience. And there's new guidance on masks. There's new information on vaccines. And we're going to welcome at 4 o'clock Eastern time, Dr. Virginia Kane, who is what's her title, Dr. Nabert-Stevens?
She's head of the Indianapolis Department of Health and a professor at IU.
So she is, I can call her the truth, and she will be joining us at 4. So I would like, Barbara, do you have some of the statistics that we talk about every week, and then we get into our discussion? And
I
Let's get
do.
on with it.
Simon will cue it up for me, and then I have something at the end of the data to kick us off on relevant topics. You can go ahead and advance it, Simon, please. Thank you. Oop, you missed one. Go back, please. Oh, no, you're right. You're right. I think I can't read. I looked at total cases and saw vaccine. I don't know how I did that. Okay, so according to the CDC, yesterday's tally, which I think all of us have sense enough to know is an underestimation of what the real numbers are, because there are many, many people who are testing at home and not reporting that they are positive. But the official results that they can collect from their official agencies, health departments around the country, since the beginning of the pandemic, they are tallying 65,159,554 cases. Of those reported cases, 12.2% were attributed to African Americans. According to them, yesterday, new case count was 874,087, although I saw another estimation from another source, over 900,000, and that probably is an underestimate as well. Total deaths are reported to be 847,577. I don't know if you all have noticed the similarity of those two numbers, but they've been running neck and neck for the last 3 weeks or so. Of all of the deaths since the beginning of the pandemic, 13.4% are attributed to, of those 847,577, I want to make sure I'm clear, are attributed to African Americans.
May I ask a question right there? And I don't want to put anybody on the spot, but can somebody convert that number of 13.4% of all deaths were African American? What percent of the African American population would that 13.4% represent? I think that would be a much more revealing number. Does that make sense?
Yeah, I'm just thinking how it could be done with the information that the CDC gives. We know what percent of the US population is African American. We know what percent of these deaths were African American, but I don't think that gives you the number that you're trying to get to.
Well,
so let's do some basic math. I can't do it right now in my head because I'm not that smart. But I think if we know the total number of African Americans in America, and if we know the total number of deaths from COVID, we can take 13.4% of the total deaths. That'll give us a number. And then we can put that number on top of the total number of African Americans. And I think that would be the answer to your question, Dr. Maxey.
yes.
And if you want to convert that back into a percentage, so then we could talk about how many what percentage of African Americans have died from COVID.
Well, the number that 13.4% represents is available. And I'm sure, I mean, it's in the CDC table that I use each week. And the total African American population, if not in that table, I'm sure we can get. So
Can I do a little just a little neighborhood math, Dr. Maxey, in response to your question?
Sure.
It's a lot of us.
yeah,
It's
Okay.
a whole bunch.
it's a whole bunch. It's over 1 million.
So it sounds like it's disproportionate. But anyway, that's the point I wanted to make.
It's always disproportionate.
Okay.
I mean, it didn't just become disproportionate. Ever since this whole thing began, it started. And Dr. Rhonda Johnson is trying to help us out. If you can work with her, Dr. Walks, and let me continue. And the daily deaths reported yesterday were 2,596. Again, I'm quite sure that's an underestimation. Next slide, please. The number of fully vaccinated, meaning 2 doses or 1 dose of a single dose vaccine, has reached 209 million, or we're knocking on 63% of the total population. Of that number, 9.9% are attributed to African Americans. And I still am not able to get the demographic breakdown from the CDC data on the number of African Americans under 65 that have received the booster. They are only providing over 65 data right now. But the total US population that has received the booster is 38%. I see Dr. Maxey has given us an interactive activity today, doing this arithmetic. Where are we with the math, Dr. Walks?
Oh, I did the math. I'd said it was a lot of us because so let me be very serious for a minute. My first degree was in mathematics, and I know that the one thing you don't want to bring to a math number is inaccurate numbers. So we don't know actually how many cases there are. We don't know exactly how many people of color or African American people have died from COVID. So yes, we can get an estimate, and I'm sure somebody can do that. For me, I go back to one of my favorite mathematicians, the Reverend Jesse Jackson, who said at the beginning of this, we are the sickest and we are dying the quickest. And I think it's important for us to recognize that the disparities that drive these numbers have existed for a long, long time. A lot of good science behind the fact that the disparities are there. And just even the percentages, Dr. Neighbor-Stevens, that you have put in front of us make it very clear that we have a disparity in all of this, which is what we keep saying every week. So yes, somebody can do the math, but I have enough math to make me know how serious this is.
Okay. Well, the next point I'd like to bring up regarding this, there are several things that are very true. Early on, many of us were somewhat miffed that they would say that Black people are sicker and have more conditions that allow us to be affected by these various viruses. And we're saying, why would you say that? But that is actually true. So that is one thing. We are, as a group, more vulnerable, and we need to speak about that. We speak all the time about the virus, but the virus is just there. It is the physical and mental shape that we are in. That's one. Number two, there is the confusion generated by misinformation. And then there is the other issue that I think is totally political or military, that if you have 100,000 soldiers on the battlefield and you have one, and I'm not a military person, Dr. Walks, and you have one company of 100 of those 100,000 soldiers, and you put them in the front line, so they get shot first. That is also political. But let's talk for a moment about these conditions that lead to people getting this virus and being affected more seriously. We know that, and I've had a number of consultations from the East Coast, from Massachusetts, even from Vermont, Dr. Steiner, from Washington, D.C., from Columbia, Maryland, from New York City. And the case, for example, in New York City was of a gentleman in his mid-60s who is morbidly obese, meaning that his BMI was greater than 40. So he is obese, and he was a happy-go-lucky Jamaican gentleman. And he was also a smoker, I believe. And he is now in the hospital in Brooklyn, intubated, and recently was started on dialysis. And we got a consult pending on him from Dr. Salafu, who is one of our star physicians, who's chief of medicine at Downstate. We have another gentleman in Maryland who is a diabetic, an amputee, and a renal transplant. And he was fully vaccinated, but he socialized. And he was put on a respirator and on dialysis. There's other people who were in the state of Pennsylvania who didn't go out at all, but they had home health come into their house and presumably brought something to them. There are also people here in California who have various types of obesity, diabetes, hypertension, and then a large number of people who think that God has to tell them individually that they need to protect themselves. So I wanted to discuss some of the things that we have to do that are common sense to me to stop some of this sickness going on. And we have to first recognize that we have to take care of ourselves much better than we currently have. And if Dr. Walks, is Dr. Hines with us today, Dr. Walks?
Dr. Hines had some challenges getting on, but she is on her way to dealing with those challenges, and she will be with us.
Okay, so let's just talk about some of the conditions that we need to correct to make ourselves less vulnerable. And then when Dr. Kane gets here, we can talk about some of the actual things that fit the guidance. I heard one of the senators from Louisiana today saying that if you had previously had COVID, that you don't need to wear masks and you're more protected than you would be if you got the vaccine. But before we get to the vaccines, can we talk just a bit about the comorbid conditions that lead to disease and early death anyway, and also contribute to you being more vulnerable to this situation of Omicron and Delta?
Dr. Maxey, before we launch into that, could I do the last slide?
Sure. I'm sorry.
That's okay. I wanted to share with everyone the information that is going to be active on January 19th. COVIDtest.gov is the website that you can go to order your free at-home COVID test, 4 per home. And I want to make sure that we gave our audience that information. So it is COVIDtest.gov, available beginning January 19th. There are some other comments I would make, and I think I will make them later on when we're talking about guidances and what the government is doing in general. But this is the information, COVIDtest.gov. I'm repeating it 3 times to make sure that our social media audience gets it. Okay, I'm through, Dr. Maxey.
Okay. I want to discuss some of the things that, and I just want to bring them up as topics. I don't want to discuss them just by myself, but we have many of our medical advisory board on. We have Dr. Jordan is on, Dr. Gibson is on, and I noticed a few others are on. And I just wanted to have a roundtable discussion on what we can do about some of these comorbidities that leave us more vulnerable. And I also like the topic that Dr. Jordan brings up every week, which is so true, that a big number of us, I'll use Dr. Walk's number, I like that better, a whole bunch of us don't have primary care doctors. Our primary care is gotten from the emergency room or from urgent care centers or from Miss Smith down the street. And that leaves us very vulnerable to all these things. So Dr. Jordan, what type of relationship should we have individually with our medical community? What should Ms. Johnson have as part of her health plan that would help keep her healthy other than going to an emergency room? And what is a primary care doctor?
Yeah, thank you. It's a lifestyle that we need to change. We need to be encouraging our people to get a doctor and to have someone. We have enough churches and enough sororities and fraternities that if we really got together, we should be able to get most people now enroll in something. And we have to realize historically, go back to when we were kids, there weren't that many Black doctors. In my hometown, my dad was the first Black chiropractor in this country, but there were no primary care doctors. There were two white doctors, one who would treat Black folks and the other would not. The hospitals would not admit a Negro into them then. So I think a lot of us have come from a system where we didn't do anything, but we can change that now. And I think we need to do a better job of encouraging people to sign up to have a primary care doctor and stop going to urgent care centers and emergency rooms and VD clinics as their primary care. They're there, people should use them, but we overuse them too often. I look at our AIDS clinic, and in the past 2 years, we have had one patient referred from a primary care center other than the VD clinic. You ask the kids, where are you going? We're their first source. They don't. And I think that's a major problem that we need to deal with, period. We've seen it with HIV, we see it with hepatitis C, and we're gonna see it with COVID. We need to do more things with the NMA, with the church conventions, sororities, fraternities, to do outreach to get Black folks into primary care. Too many who should be are not. And that's our problem.
Let me bring up something, and this may or may not be controversial. We know that even if every Black person here tried to see a Black doctor, that's impossible. We just don't have enough. We do have a number of other types of providers. I have always worked with physician's assistants in my office. And recently I have started to work with nurse practitioners. And I know that many physicians have different views of this level, but I'm wondering if in getting our people primary care providers, what do we think about having people see nurse practitioners and PAs, at least for primary care, if not specialty care? Any thoughts on that, Dr. Jordan?
I agree completely. And it hasn't got to be a Black doctor, but it is ridiculous when a 50-year-old man comes in or a 45-year-old woman comes in and he or she has never seen a primary care doctor other than going to some emergency room somewhere. In Los Angeles, there are too many physicians that there's no excuse for someone not having someone, period. Now, if you're in the rural Mississippi, it's a whole different story. But for Los Angeles, New York, Chicago, there really is no reason why we can't go to see someone. He or she hasn't got to be Black, but you should have a doctor. And you come in with a blood pressure of 240 over 120, and this is the first time we've seen you. Makes no sense.
I couldn't agree with you more, Dr. Jordan. But, sometimes I have my moments like Dr. Maxey has his moments. And my moment this week was, I am sick and tired of hearing people describing a problem or describing a situation. I am more than ready now to start hearing and participating in doing something about the problems that have been identified. A long time ago, at least 5 years ago, I stopped going to health disparity conferences because I don't need anybody else to tell me that we have health disparities. What I want us to do is figure out what we're going to do about it. So specifically to the point that you were making, Dr. Jordan, yes, not only are there healthcare providers sitting there, I'm not saying they're twiddling their thumbs, most of them are pretty busy, but I do believe that there is some accountability on the part of the patients. And if the issue is, and I am an advocate for patient advocacy, if the problem is our people don't know how to connect, then we need to start putting in place educational programs to identify for them how they can plug into the healthcare system, how they can plug into insurance, whether it be private or public, or whatever other barriers they think that they have to getting into the healthcare system, helping them figure out how to avoid that. If we need, maybe we can start that with one Sunday talking about that. We've been kind of kicking that around a while, and maybe it's time to do that. But for, all of these problems that we keep discussing, I don't want to hear about them anymore. I want to hear what we're doing about them.
Well,
So
Thank you.
let
I
me
agree.
let me jump in with 2 points real quick. One is that Dr. Hines was able to join us. So if we can get her unmuted, she can jump in and give us an additional perspective on this. Dr. Neighbor-Stevens, I think that I make a lot of assumptions. I think that when I say NMA, somebody knows what I'm talking about. And it's interesting, in the chat, Dr. Gibson, who always has something positive to say, put in the chat, try the NMA. Right below that is someone who said, what is NMA? So I think we have to be really clear that our audience here at Black Health Trust is very diverse. I think it's important that we follow what Dr. Neighbor-Stevens said about what is our solution? What is our intervention? What is our proposal? And so I want us to take that under advisement and see if we can put a link through people obviously who are here know what Black Health Trust is. Can we put a link to Black Health Trust that has a name? I mean, has a list of primary care practitioners, not just physicians, but primary care practitioners in different areas. Does that list exist somewhere? I'd like to ask Dr. Hines, put her right on the spot since she joined us and she is a leader in the family practice community. When I think about primary care, I think about family practice docs. So if someone is looking for a primary care practitioner or a family practice doc, Dr. Hines, hopefully you can get unmuted. What is it you would tell them if they call you from another area? Because we have folks on today from every place from Buffalo to LA.
And let me add one thing to what you're saying, Doctor. I like to have a patient who comes with a list of concerns so that I can go down that list and address those. But go ahead, Dr. Hines.
Okay, wait, Dr. Maxey. We need to have a whole nother little piece on what the patients need to bring to that first meeting. It isn't just their list of concerns. Bring a gallon-sized Ziploc bag with a bottle of every medicine you take and every vitamin you take. That's a whole nother conversation. But Dr. Hines, please.
So again, I apologize for I was having some technical difficulties, but what I understand the question to be is how would somebody go about finding a primary care doctor? So here's what's tricky about this, right? In lots of times the temptation is to go for recommendations from friends or family, but that can be difficult because you don't know who takes your insurance and all of those kinds of things. So in general, what I usually recommend for the insured is to go to member services on their card. There's a number for member services, or they can, depending on if they're internet savvy, and use their use their insurance company to help them determine who meets the criteria that they're looking for. So for example, if you're looking for a male or a female, or you're looking for certain languages, or you want them to be in a certain, miles from your workplace or from your home, you can put those things in. You can search your insurance companies providers list, and they'll have the most accurate information of who's taking your insurance and who's taking new patients, that kind of information. Then after that, let's say you had a list, right? Let's say there was more than one person that met your criteria. Then that might be a time where then you could then go to ask, family, friends, anybody know about Dr. Whoever. So the tricky thing with using some of the health grades and some of the websites is there are excellent providers who have poor ratings. And then there are not so great providers who have great ratings. The same as if you went on any, if you go on Amazon, right? You could find a product that you love, right? That other people gave 2 stars, but you'd give it 5 stars, and vice versa. So using the internet for objective information about an individual can be a little bit tricky, but you know what things are important to you. One of the other things that if you are not insured and you're looking for a primary care provider, usually the first thing I tell people to do is look up federally qualified health centers in their particular area, or their local health department will oftentimes usually have a link or resources or information about clinics or providers in the area that are seeing people without insurance. If you are uninsured and looking for a primary care provider, just because somebody works at a clinic that serves folks that do not have insurance does not mean that you're getting substandard care or you're getting doctors that have no place else to be, right, or anything of that nature. I spent the majority of my career working at federally qualified health centers because it was a passion and a love of mine. So that is a misconception that people have, and that's something also that keeps them from getting care. The last thing I will add too is there are sometimes people who have immigration issues that keep them from engaging with primary care. And there's this thought that if I get in the system, people will find me, or that's another reason why people don't go for healthcare. In general, there is no obligation or rules that say your immigration status needs to be tied to your healthcare. So that does not need to be a barrier to getting primary care services. And so, then I will just briefly touch on Dr. Maxey's point about what people need to bring. I think another issue that people have when they're new to entering the healthcare system is about expectations, right? And to your point, in addition to all of the historical information that people want to bring to the doctor's office, even if you bring your list of concerns, which is great, there has to be some level setting about what things we're going to be able to get to during our more than likely 15, and if you're lucky, 20-minute visit, right? So usually initial engagements it's going to have to be a collaborative effort to get through that list of things. Because for a lot of people who've been out of care for a while, their list may be 10 things long, and their top priorities and my top priorities as a physician may not necessarily be the same thing, right? So you have to establish that relationship quickly and then work together to say, okay, but if we need to see each other every 2 weeks until we can get these things under control, then that's what we need to do. But how about you pick a top priority and I'll pick a top priority? Because yours might be your ingrown toenail. Mine might be your diabetes. So we have to work together to kind of work to get through that list. And sometimes, again, that's a reason why people will go to primary care, get upset because they didn't talk about all the things that I wanted to talk about. And that can sometimes be a barrier for people staying engaged in care because it's a process. And lots of times not understanding that or not having the expectation can be a deterrent for people.
Dr. Hunt, may I ask a question?
Sure.
In prioritizing the patient's so-called problem list. Would you think that we should ask people to know what are the things that cause the most morbidity and mortality and put those close to the top of the list, in addition to the ingrown toenail at the bottom? But what are the main killers of people in communities of color?
So to answer, I think there were two questions in there, right? The first one sounded like, do I think it is the patient's responsibility to know what's the highest, got the higher morbidity or mortality? I don't think it's the patient. Was that not the question?
No.
Okay, repeat what was the first part of the question about who needs to know about
should we as physicians and should we as a group concentrate first on those things that can put you out of the game? What are the things that can cause the highest rate of morbidity and mortality, and then be sensitive enough to find out about the other things that may be on a patient's mind? But I agree with that. It's a process that we need to go through. But the more we educate people about their concerns, I want to first let them know that they do have some responsibility, as Dr. Neighbor was saying, to know the things that are in their family, things that are in them that can kill them or hospitalize them or make them more vulnerable.
So usually what I used to do was, if I had somebody new and they brought me a list, right? If let's just say, for example, I was concerned that they might have, serious heart disease, right? And they're concerned about, for example, their ingrown toenail. The reality is, it's not totally for me. We like I said before, we have to decide what this relationship is. My concern about your heart disease risk and making sure that we get that evaluated and, work on those risk factors and things like that. How I come at that is usually from the point of view of not just morbidity and mortality, but your quality of life and what are the goals and things that are important to you. Your ingrown toenail has to stay important because you told me about it's high on your priority list because it's impacting your day-to-day life experience. So for me to ignore it because it's not going to kill you is going to ruin our trust relationship. Because if the answer is you can't go to work or you don't want to stand on your job and do, stand for 8 hours a day or wear shoes or whatever, I have to get to what's important to you, as well as what might shorten your life or keep you from getting to those things that matter. Part of how I would establish a relationship is understanding what matters to people. And if what matters to people is supporting my family or seeing my grandkids or whatever, I'm going to talk to you about the importance of your heart disease, not from a statistical point of view or what role that plays necessarily in your community, unless you told me that that's a serious important factor to you. I'm going to talk to you about it from the point of view of why that's going to be important to you as an individual. It'll keep you from working. It'll keep you from being the provider. It'll keep you from playing basketball with your son if that's what you want to do, right? The horror of what it would be like. That's how I come at morbidity and mortality with my patients, is from their individual perspective. As well as these, and then later on for the other things where there isn't necessarily an immediate connection point with their experience. Lots of times I find diabetes is one of those ones where the true implications of it and is so vast, it can be overwhelming, because I don't want to overwhelm people with, here are all the things that could happen. And if you don't change stuff right now, here's the breadth of this. Did you know that 1 in 4 people have, blah, blah, blah. The likelihood is, yes, they know it, right? Because it's their family and friends and cousins and aunties, and their dad had it, and which can work in my favor sometimes, because they may have seen it as devastating, or they might also see they live with it and they do whatever they want to do. So I'm not really sure why that's a problem. It can go either way.
I'd just like to jump in on that and say that what Dr. Hines is describing is or the lack of what Dr. Hines is describing is unfortunately a broad problem in the way healthcare is attempted to be delivered. Physicians have an agenda. They have an agenda of wanting to get you as well as possible, as fast as possible, and to help you stay well. The patient comes there because something, which you have yet to figure out, is bothering them. Because generally speaking, especially if you're talking about Black patients, they're not going to go, or they're not going to come until there is an issue or a problem or a reason driving them there. Because our tradition has not been around prevention. Ours has been a reaction to a situation. And unfortunately, it has frequently been a bad situation with a bad outcome. So we don't look forward to going to the doctor. That's just not part of our tradition. So the number one thing that has to happen when the patient comes in is there has got to be the establishment of a treating partnership. There cannot be this agenda of all of the health education in the world that needs to be given around whatever problems you've identified. Yet it's going to have to get managed, and it takes time. It's not going to be in that first visit necessarily, but you won't have a second visit or anything that you say will be dismissed if the first thing you don't do is develop that treating partnership so that there is understanding and agreement on what we're going to do. It cannot be, you have diabetes, you need to get your insulin and you need to take it twice a day and check your blood sugar 3 times a day. It's going to have to be a partnership that agrees on that treatment plan, and that agreement is based on an understanding of what that treatment plan is and what the goal of that treatment plan is. And that is one of the biggest failings that I see in the way medicine is practiced in this country today.
Well, I was always taught, and I think it's important to say, that a patient doesn't care how much you know until they know how much you care. And if that is established immediately early on, that you do care for that patient, that will help that partnership that you and Dr. Hines were speaking about. But back to what Dr. Jordan was speaking about, and I think we ought to do this in our future programs, is let's help provide information to our listening audience about the things that they can do to help prevent and ward off being to the doctor at the last minute when it's too late or when it requires surgery or things like that. Dr. Walks, why don't you jump in this a moment?
So what I've done for many, many years when I see a patient is I always ask them, whenever I say, whenever we finish up, I want you to send a note back to my office with exactly what you and I agreed you were going to do. Because I don't believe in doctor's orders. I believe in doctors making recommendations. People don't do what we ask them to do all the time anyway. You know, I want you to take this medication 3 times a day. Really? Who does that? So I think that when folks send back a note that says what they're going to do, I hope it agrees with the note that I made when I was seeing them. And that's the purpose. Well, don't you know what you told me? Why am I sending this? I asked you to send it back because I want to make sure that it's clear what I asked you to do and what you're going to do, because it keeps us both clear about what I believe that person is doing and what they believe they're supposed to do based on the interaction. Let me make one other quick comment, going back to what Dr. Hines said. If you don't establish a relationship with someone when they come in, if you're just the doctor ordering tests and prescribing stuff, very, very low likelihood that you're going to get the outcome that you want. And I think a lot of it goes back to something very basic, especially in the African-American community, which is respect. We have to respect people enough to understand the importance of collaborating with them. That was put in the chat Motivational interviewing starts a collaborative dialogue. Gerald Bryant put that in the chat. Really true, really important. Letting someone know you value them matters so much if you really want them to do something, because we're not talking about health education as much as we're talking about motivation to get someone to do something, change a behavior, take a pill, whatever it is we want them to do.
But let me flip the script on this.
Wanted to make a point.
I want to ask a question, because you clinicians have enough tasks to do in your clinical care of patients. So there are some tools that can assist you that we use here in Buffalo, particularly with the minority physicians who are members of the NMA Buffalo branch, the Buffalo chapter. We use a tool called Patient Activation Measure. And it's a short survey in which it's interactive between patient and physician, or between the physician's PA or nurse practitioner and the patient, and really is designed to do health education in a very short period of time. It's a short survey. It's got like 5 questions that are asked, and then it really empowers the patient to be a partner in their care. And that's really what we need people to become, partners in their care, because it doesn't matter what you do as far as a clinician, if when they leave you, they do none of the things that you suggest.
Yeah, I think that's very important. And in fact, I was about to say before you spoke, I wanted to flip the script. My primary interest today is not what the doctor does, but it's how the patient gets an interest in themselves. For example, when you select a lawyer to defend your relative of first-degree murder, you may interview several lawyers to figure out who fits with you. And likewise, you should interview a healthcare professional to make sure they fit with you, because it's in your interest. And you can go to a pill pusher doctor, you can go to a doctor who prays, but you should find a doctor who fits with you. And I agree with what Pastor Pointer is saying about that. And I sure would like us to be able to see that 5-question thing that you have. But I think we need to motivate the patient to take the responsibility of finding healthcare providers who can help them and inspire them. And you can go to a Ku Klux Klan doctor and make him treat you right if you ask the right questions. So I'm not trying to motivate doctors. I'm trying to motivate the patient to demand and require the right type of treatment for him or her family. I'm interested in having our patients become more interested in their own health. My youngest daughter and her mother are total health people. And she wouldn't think of eating the type of diet that I was raised on. She wouldn't think of putting her body at risk. My younger sister is the same. So if we can do the type of education here to make people know how to treat their bodies right, and then also to make sure they interview their healthcare provider. So not only have a health provider, but get one that is compatible and that expresses care and demonstrates care for them. That will go a long way. Now, as physicians, we have to be responsible for getting our act together. That's not the topic of the discussion. The topic of the discussion is how we can be better compliant as patients to treat the ones we love and ourselves and demand that type of care. I don't go to a doctor and just listen to anything they say. They may say something totally dumb. So we have to put a certain amount of knowledge in our patient base, educate our patients. And we need to do that, I think, on this program. We're not, the NMA, the National Medical Association, part of its job is to educate its doctors. Our point on this program is not to educate doctors. It's to educate and care for our community, I think. But I'll open that to question. Like, I'm concerned that when patients come to see me and they have a blood pressure of 1 million over 2 million, that we can communicate on that. And I believe most things start with diet and how you take care of yourself. And we know that you must eat right, you must exercise, you must get a certain amount of sleep. It's very basic stuff that we need to start with. And also the information we provide on this program tells people, they've been told by physicians at Cedars-Sinai that it's all right for your pressure to be 150 over 110 because you're Black. They're being miseducated. And we can correct that as doctors, but we need to know our patients know what they're thinking and what they're being told. We need to do community education. A lot of people are concerned about having colonoscopies. They never heard of a colonoscopy. Or we have this thing, we don't want something going up our butt. But by the same token, we know that most cancers of the intestine are within, a finger's length of the rectum. But a lot of our people don't know that. So we need to do that type of education. Now, privately, the NMA and us on our private meetings, we need to talk about how we do our end to develop trust. But we need there's so many patients that are ignorant of what they need to know and what they need to do. And that cannot be. The white patients I have, they come in, they demand treatment. They demand you look at this mole on the bottom of their foot. The Black ones don't. They say, doctor, whatever you think. That's not acceptable.
That's exactly what they say.
We got to stop being dependent.
Yep. But we've also got to realize there is a significant number who cannot read. And I've learned over years when someone just says hostile and I'm too busy to do something, I will simply assume that they can't read the form. And I'll just say, oh, let me ask you the questions. I can fill this out because I know what they need to do and we can go and get things done. And again, I'm surprised at how many young persons, male and female, cannot read at all. And that's a problem also. I mean, it's not a huge number, but it's a significant number. And it's a time-consuming number when you have to deal with those things. But if you can finally be the one who can sit there and say, let me ask you these questions, let me do this, you can get it done. Because otherwise they walk out, they don't go to the health educator, they don't go to the case manager, they go home.
So Dr. Jordan and Dr. Maxey, I think one of the considerations for us as we talk with folks about community health resources is that not every community has all of the resources. We talked earlier about, I know Dr. Hines talked earlier about folks looking at federally qualified health centers if there aren't other kinds of providers available. So there are a lot of different types of deserts in our communities. There are food deserts where folks can't get nutritious food to buy. There are health shortage areas in many of our communities. So I think ideally, we should be able to interview and pick and choose and make demands. I think practically, we have to get where we can get and get what we can get. And at the same time, try to make resources more available and make resources better. And I'm not talking to the doctors, I'm talking to the people who live in the communities that can come together, that can look at other kinds of approaches, including who's on your city council, who's your health department director. There are a lot of things that folks can do to influence the resources that they have. But the bottom line is everyone doesn't have the same level of access to the same level of resources. And we just like Dr. Jordan was talking about, we just want folks to go to the practitioner, go to your doctor, go to your nurse practitioner, find out what's going on with you, And back to, again, to a very important thing that Dr. Hines talked about, what's important to the patient? Tell the doctor what matters to you. Tell the doctor why this particular ingrown toenail matters to you, and see if that can be a way of connecting with that doctor.
Thank you so much. Let's move to the next area of concern. We're waiting on Dr. Kane to join us, but there's some issues that I'd like us to consider. Let's say that you have a mother who's 95 years old, and she doesn't go out, and she has tested positive for COVID. She's asymptomatic, but she's positive, and she's had 2 rapid tests, but she's asymptomatic. Her daughter, who she lives with, is also positive. She's fully vaccinated and boosted, both of them are, but she's symptomatic. She feels ill gastrointestinally. She has some shortness of breath. What do we recommend in that situation?
For who, the daughter or the mother?
Let's talk about both of them.
Well, they need to be, as much as possible, separate. The daughter needs to be followed closer by whomever, whether it's me, the primary care doctor, et cetera, because she is symptomatic. She doesn't sound like she needs to be in the hospital, but someone else needs to be dealing with the mother, because the daughter is still shedding. And the more she's around her mother, the more her mother can breathe in more virus, and she can become sick. She's 95 years old. So a 95-year-old, when she catches on fire, is a hell of a lot harder to deal with than a younger daughter. So for her, I would like to have her call the nurses and report every other day as how she's doing. That's what we do with the OASIS patients. And she can tell how her mother's doing. But for the mother, it would be nice if there's a home care or someone could go in and sort of see her, rather than her having to go in and continuing to see her. The more she goes in, the more she's going to expose her mother to more virus. And I doubt if we have a time to really give her a 101 on how to do things. She has to wear a mask, etc. I think those things are very important. The most important thing everybody should be doing is wearing an appropriate mask if you have been exposed, period. You don't go and see anyone at all without putting a mask on.
Okay, Dr. Hines, would you comment?
Could I
Dr.
interrupt before Dr. Hines starts? Dr. Kane just called me. She has tried 3 times to get on, Simon, and it keeps telling her the host has another meeting going on. Do you have any ideas of how she can get on?
I'll resend her the link personally.
Okay, thanks. Simon is going to send you.
Okay. Dr. Hines, would you care to opine?
So what I didn't really gather was unclear to me is the 94-year-old reliant on the daughter for her daily care or not?
Yes.
Okay. So
in addition to there being home health care going on.
Oh, so they're getting home health care services even while they're positive?
They were, yes.
Well, so there's 2 different things, right? If we're talking about from, what care should people receive, that's you need to call your primary care doctor, and then your primary care doctor tell you what's the most appropriate, actual care for you, right? But if we're talking, so what I like about Dr. Jordan's suggestion about getting to see if there are other people that can assist if the daughter can't do that, as someone who's kind of been in a similar scenario, lots of that stuff doesn't happen very quickly, unfortunately. It needs a lot of lead time to get new people in, but you're saying that they already have people who are helping them with services. So I would agree with limit the daughter's contact with the mother as much as possible, as long as there are other people, and wear a mask as long as there are others who can assist. And what's the rest of their support system? Are there other family, friends who can help, who also may not, so the plus and minuses of everybody having Omicron at the same time is that everybody's got Omicron at the same time. So is there anyone else who's recently recovered that might be able to assist and fill in the gaps for what the things that the daughter can't do in the short term?
There's a granddaughter who's a professional, who happened to be a pharmacist, Dr. Gibson.
Yeah, that would lean on the other supports. Like, this is when you ask for help, right? Like, we can't do things the way we normally do. And so who can we lean on for some help that we are not also putting at increased risk? Because that's the other thing. You don't want to call somebody in to help and then deal with creating a whole other chain of, infection. But as far as their overall medical treatment, that's when everybody needs to talk to their primary care doctors, because there are things that are available to them. The 94-year-old is at higher risk, right? Maybe there are some things, even though she's asymptomatic at this moment, whether or not there are other things that should be done or not done for her, all of those things need to be discussed as far as their actual treatment of their.
What are some of those things we might suggest?
Oh, well, they've got the monoclonal antibodies, they've got the antiviral pills that are out there, but all those things have, criteria and inclusion and timing and all of those factors, whether or not that's available in your area, whether or not, where's the window between the time you got sick and when you're making this call, your other health conditions, all of those things have to be weighed in and would be discussed with both people's primary care doctors.
So Dr. Maxey, another component of this question is, Dr. Steiner gave us a very good talk last week about the importance of planning for COVID. Anyone who hasn't thought about getting COVID by this time really should. And so it isn't only those who get sick and now, what do I do now that I'm sick and this person has this issue or this prior condition? Every single person that any of us even thinks we know should have a conversation about, what do you do if you get sick? Who are you living with? How are you going to do this and that? We talked last week about the kind of air filters in the house, because while you're isolating in one part of the house, your HVAC system is blowing Omicron everywhere. We've talked about the machines, not only the one that Mr. Dorsey talks about, but others that can help with actually reducing the viral load in your home or in your work environment. So there's a lot of, going back to Dr. Steiner from last week again, a lot of thinking about this before you are saying, oh, wait a minute, I'm positive, this person's positive, what do I do?
Dr. Steiner is a board certified emergency room physician, and I think he's on. Dr. Steiner, what should we do in this individual case? And in general, what should people do? If you give a brief summary of what you told us that Dr. Walks referred to that we should do in preparation.
And while Dr. Steiner is getting queued up, Dr. Kane is on. Dr. Maxey.
Okay, hello, Dr. Kane.
We got to get her unmuted. So Dr. Steiner, if you can make a few quick comments while we get Dr. Kane unmuted.
Sorry about that. Now you can hear me. Hello, everyone. Sorry.
Hello, Dr. Kane.
Hey, Dr. Kane.
Good. Hi, Ivan Wilbur.
Good. We're just about to hear a quick comment from Dr. Steiner, and then we want to ask you some questions. Dr.
Please,
Steiner?
be honored, okay? I think
Dr.
Dr. Steiner is saying he can't unmute. Dr. Steiner is saying he cannot unmute.
There we go.
Okay,
Dr.
I think we got it now, right?
Okay.
Thanks, Dr. Walks, Ivan. The plan is the most important thing, and it goes not only for COVID, but it goes for when you see the doctor. And that's what Dr. Maxey and you were, alluding to, is have your plan. What medicines are you taking in? What do you want to get accomplished? And how are you going to communicate this to the doctor when you're there? And most often I found, like most physicians, is the patients come in and they're disorganized, and then they're not making it easy for the doctors. And I think if the patients have a plan as to what they want to get accomplished to begin with, and what's the purpose of the visit, and what they want to get accomplished at the end, like you alluded to, at the end, they want to tell you what they heard from you. So you're both on, the same wavelength, and you both understand each other. And often that's a real barrier to care. So, Dr. Maxey asked how I would approach these things. And I always say a plan works best, and write it down. Write it down. A lot of people say, I know what I'm going to say when I go to the doctor, and they can never remember. It's real common. I think every practitioner, right, on here, this is what they get all day long. And if they come in with a written to-do sheet, this is all I ask them. What do you want to do when you come in? And bring a list of the medications that you're taking. And then we can start communicating with each other. So I think it's frustrating for the patients, and it's frustrating for the doctors, but I think the patients have to share some of this burden and just write down what they're coming in for clearly. What are the issues? Like Dr. Maxey says many times, there's 7 issues they're coming in for, and it takes forever to weed through each one. And so I like to go with a priority type plan. Let's start with what's bothering you most, and see if we can cover it in that visit. And then, of course, when we leave, sometimes I think it's good to put it down in writing, not only for yourself, of course, in your office notes, but for the patient as well, to walk out with, besides a prescription that is very clearly, he understands the marching orders, so to speak, that you're both on the same page, that you're both going to accomplish this till the next visit. And it comes down to communications. And I might say one last thing. My practice was about 25% minorities. I practiced in a town about 10 miles outside of Newark. Maybe at times it was almost 50%. And we never treated patients according to ability to pay. If they were sick, come on in. And I think that in areas where there aren't a lot of minority physicians, and certainly in New Jersey, I was surprised. There's mostly Indian physicians, I would say, as the lead at this point. But Black patients don't have to go to a Black physician. White patients can go to a Black physician, and that shouldn't be any barrier to care whatsoever. So I think if you find that a barrier to care, you should contact your local medical society and let them know about that, so there can be an action on that. But I think all doors should be open to all people, and I'm hoping in the future we see more of that.
Thank you, Dr. Steiner. I'm going to say one thing about your plan. There was a famous philosopher recently who said, the plan is good till the first time you get hit in the mouth. That's Dr. Mike Tyson. But Dr. Virginia Kane, who was a former chairman of the board of the National Medical Association. She is a well-respected specialist in infectious disease. And currently, what is your job now, doctor? And we'd love to have you comment.
I got two. I'm Director and Chief Medical Officer for the Marion County Public Health Department. That's the health department that serves Indianapolis. And I'm an Associate Professor of Medicine, Division of Infectious Diseases at Indiana University School of Medicine. And I practice in the 5th largest public health hospital called Ashkenazi Health, that sees are predominantly indigent in a significant number of Medicaid patients.
Well, let me start off before the other moderators jump in. I was looking at CNN today, and they had a senator from Louisiana, Senator Bill Cassidy, I think his name was. And he was saying that he was sure that if a person has already had COVID, that the immunity given that you have post-COVID is stronger than the vaccine.
He's incorrect. So studies have definitely shown that you generate a higher level of antibody production from the vaccines compared to a natural immunity that you develop from a COVID infection. On top of that, with the COVID infection, natural infection, someone should have told her, what's that guy's name that they just kicked out of Australia? Trying to get that Australian Open. They should have told him that when you have a natural infection, your immunity only lasts for 90 days. But if you're vaccinated, your immunity with at least the 2 doses for both Moderna and Pfizer, 1 dose for Johnson & Johnson, your immunity lasts for 5 months with the Moderna and Pfizer. Johnson & Johnson, though, it's only for 2 months. So, but clearly he's incorrect.
Thank you. Dr. Neighbor-Stevens?
Thank you, Dr. Kane. We have a question in the chat that I really want you to address. I'm going to simplify it because if we don't do anything, we want to make sure we disseminate accurate information. So the question in the chat revolves around the fact that some family members tested negative for COVID and then had vaccine. And then within a couple of days after getting the vaccine, they were positive for COVID. And I think implied in the question was whether or not the vaccine was the cause. But if that's not the underlying question, the other part of the question is, when you get a vaccine, how long does it take for it to be effective?
So first of all, let me just clear this up for that, whoever put that question in. There is no live viruses in these vaccines, attenuated viruses. So that means that these vaccines cannot give you COVID. That's the same with the flu vaccines. The flu vaccines cannot give you flu. So I want to make that clear. And if I can see if I got this correctly, you do not develop the full protection from the vaccines. Let's talk about the Moderna and Pfizer. These are what we call our messenger RNAs. Until you've completed both vaccines. Having 1 vaccine dose only gives you about a 50% protection. And that was with the Delta variant. So it's got to be lower with the Omicron variant. And so you really need 2 doses plus the booster if you are 5 months out from your vaccine series. And it takes at least 2 weeks after you get the vaccine for your body's response to make and develop antibodies for your protection. So if you get the vaccine shot, a lot of people, oh, I'm sick, I've got COVID, wants to get in the hospital, give me my vaccine now. Well, the problem is the vaccine takes 2 weeks, the dose, before it can develop the antibodies. That's why some people try to encourage or look at, if you have not been vaccinated and you're sick enough to be hospitalized, they have what they call these man-made antibodies called monoclonal antibodies that they can give you a IV infusion for over 2 hours, where those antibodies hopefully will last long enough to fight off the viruses that are just replicating in the hundreds, multiplying and infiltrating all the organs of your body. So no surprise if someone gets an infection after a couple of days after the vaccine, because it takes at least 2 weeks, and you really need 2 doses if you got Moderna and Pfizer, 1 dose if you happen to get the Johnson & Johnson vaccine.
Let me ask a question about multiplication, in that I understand that the difference in this Omicron is that it can double in 24 to 48 hours.
Hey, let me just say this to you. That Omicron's a bad boy. It's got over 50 mutated particular characteristics on its gene. It can replicate about 70-fold faster than the Delta variant. What did I say? 70-fold faster that it can replicate.
70
so
times
it is way,
more?
It's 70-fold, 70-fold replicate faster than the Delta variant. So what am I saying here? It is extremely contagious. Now, it may be associated with a little bit milder symptoms than we have seen compared to the Delta variant. But the problem is it's infecting a whole host of more people. And so, you know, in any kind of circumstance, when you're infecting so many people, you're going to infect somebody that's immunocompromised, okay? Their immune system has waned, or they've got such multiple chronic conditions that makes them really more vulnerable. We do know that maybe when you look at the length of time for hospitalizations, it may be 2 days less with the Omicron variant. And we seem to be seeing way more cases in children with this Omicron variant than we saw with the Delta variant. So, hey, please get vaccinated. If you're eligible for a booster, you definitely need to get that booster because your antibodies have waned over time. When I mean waned, it is lowered over time, okay?
Thank you. Dr. Walks?
So once again, thank you for being with us, Dr. Kane. And for clear, it is very challenging for most of us to sort out all the information that we get, and we get so much information. And someone was telling me, well, you know, Dr. Walks, things are getting better because Omicron is less deadly. So that means the virus is heading in that direction, and the next one is going to be even less deadly.
Well,
I said, what kind of? No, I'm not sure that's how it works.
Ivan, let me just tell you what the concern is. We used to have 3 different medications for the monoclonal antibodies. And now, because this Omicron has become so resistant, it's changed so much that our 2 major monoclonal antibodies, one from Lilly Pharmaceutical Company, one from Regeneron Pharmaceuticals, it's no longer effective against this Omicron variant. We only have 1 monoclonal antibody. And guess what? There is not enough production of this monoclonal antibody. They're going to have to pick and choose who should get it in a state.
Yeah.
Our state of Indiana is saying that we may have maybe 1,000 doses for our 8 million people that's in the state of Indiana. And let me go back about the medications now. We're in good shape because we got these medications now. We got the Pfizer medication and we got the Merck medication too. Now the Merck is only a 30% effectiveness. So, and then you got to start that medicine within 48 hours. So good luck tracking down your provider, getting that prescription in the 48 hours to meet the eligibility for some of these medications. But again, there are 340 million people in the United States. They from a protection standpoint, they don't have enough medicines to give everybody out here. And it's sure gonna be tough for people of color, okay?
Dr. Hines?
So my question is, how would you suggest people interpret the language? On the one hand, we're saying how Omicron is less severe, but then on the other hand, we're talking about hospitals being overwhelmed and increases in hospitalizations. And I think that I get it, but I think that lots of people find those things kind of conflicting and confusing in the context of trying to stay vigilant.
So let me just say this. Here's what the deal is. We may not be using as many of the intensive care units compared to the Delta variant, but we are filling up the hospital beds. People are lying in these hospital beds. And so tell me this, when you're having your heart attack, are you having your stroke, are you having an asthmatic attack, what are your chances with a burnt out hospital people that have been there for hours? I'm talking about hours, because those personnel are getting sick now and they're tired and they don't have no bed. So every hospital we've had has done diversion. That means we're packed. We can't take no new patients. So if I got a diversion, that means it's going to take you longer to get me and find me another hospital. And if I'm having a heart attack, I really need to be in that hospital within 9 minutes after you pick me up. So, hey, don't be having no heart attacks. Don't be sweeping no snow. I feel for you if you got an asthmatic attack, but you are in serious trouble. And one other thing, we can see some rare conditions. I just want to highlight this. There's some rare conditions out there with children where you can get a sore throat, or even adults, where you get a sore throat and you say, wow, this may be COVID, but your COVID test is negative, your flu test is negative, and you say, well, this is sinusitis. If you have someone who has a headache and they're talking about severe neck pain, please consider that you can get a septic thrombophlebitis anaerobic infection of those neck veins. And we can see it a lot in a lot of adolescents that you may miss this, but someone's got a major headache that doesn't want to quit, and they got significant neck pain. It's not always sinusitis, and they can die from an anaerobic infection. So septic thrombophlebitis of the internal jugular vein. Look it up, Lemierre's syndrome.
Can you translate that just a moment?
Oh, sorry, guys. So, all of us have veins. Everybody knows about the carotids, our arteries that go down in our neck, but we have something called a internal jugular vein, very large veins that, arteries carry your oxygen blood flow to your brain, but then it's got to come back in another set of blood vessels to get replenished. And so from a sore throat, sometimes, depending on, there are certain strep bacteria that are anaerobic, meaning they don't require a lot of oxygen in order to survive in their environment, that a person can have that sore throat be so significant that it can spread down into your veins and arteries in your neck. And so someone is having major neck pain, and it could represent meningitis. But if you got someone that's got a headache, sore throat, and you've tried to treat them and they're not getting better without antibiotics, be concerned that you need some imaging studies, I believe, in order to make that diagnosis in the neck. Dr. Pat Whitley-Williams, I will never forget, gave that as a case for us at our National Medical Association for us to identify for an adolescent teen that she saw. Yes.
Dr. Kane, what I wish you would do is not translate the anatomy and the microbiology, but tell these parents what they need to do when their children complain of a headache and have fever and a sore throat.
So if you have a headache, fever, and sore throat in this arena, you need to get it checked out by a healthcare professional.
Thank you.
You go to an urgent care facility or an emergency room. And if they treat your child and say, I'm going to give you some nasal congestant, ibuprofen, maybe to help that sore throat or whatever, and your child does not get better after 2 days and they're still having persistent headache, heaven forbid if they have nausea and vomiting, but if they now are developing neck pain, as a parent, when you go and get your child checked out again, and they're just saying, oh, it's just taking a delay for my child to get better, you rush and carry that child to another hospital to get them evaluated. Do not let them discharge your child if they've continued to have headaches and it has progressed and gotten worse.
So Dr. Kane, let me ask a question that's kind of in line with what Dr. Neighbor-Stevens was just getting at. So many times we just need to know what to do. And so what Dr. Neighbor-Stevens had put up earlier was the website to get those free tests that the federal government is going to be able to send out. What I've told a couple of folks is it's challenging. It's challenging currently to go out and get a COVID test when you're concerned about maybe I have COVID, especially right now in the DC area because it's snowing for all get out. And we do not want to go stand in the snow for 2 hours to get a test. But here's the issue. Some of the things that we can actually do at home that can help us decide, when do I need to go to the urgent care? When do I need to go to the hospital? Because there's sick people in the hospital. They might give me something I don't have if I go to the hospital. I shouldn't be going there all the time just for anything. What about the at-home pulse oximeters to let you know, wait a minute, this is not just a cough. This is not just something I can just wait at home because my oxygen level is going down. They don't cost very much. You can get a pretty good one without spending a lot of money. And that can let you know, hey, something is happening that I can't handle here at home. Can you talk a little bit about how do you know when it's time to go get some help?
Well, first of all, I think the major thing, at least for me, is that I think a fever is a major trigger. Okay, now you can get a fever with a viral condition, but unfortunately, you can get a super infection on top of that viral syndrome. And with this, with these conditions so deadly, and it can go so fast, if someone has a fever over 100 degrees, I think they need to get that checked out, especially if they have sore throat and they have a headache associated with it. Now, a lot of the COVID is resulting in symptoms of pneumonia. These patients get pneumonia. So they have shortness of breath. And so if you've got an underlying condition and they've got shortness of breath, they should be getting better as the day progresses. But if you have someone in over 24 hours and their shortness of breath is not getting better, it is getting greater, definitely do not wait. Have someone check that out. Someone needs to listen to those lungs. Don't necessarily have to have a chest X-ray, but listen to those lungs. The other thing is you can get chest pain. You can get inflammation of the heart associated with COVID. So someone is expressing that they've got significant chest pain. That one you can't wait. If that chest pain is persisting greater than 30 minutes, you need to get in to be seen by your provider. Now, I know I'm crazy, but listen, there have been studies to show that Listerine is very good against killing the COVID coronavirus. So, hey, I love making sure I'm rinsing my mouth every morning with Listerine. I'm not trying to sell a product, but I don't know if it's the alcohol that's in there killing it or what. But I know I haven't gotten COVID so far. And trust me, I've seen a lot of people. My state health commissioner just got COVID for the second time, Omicron. So maybe I'm just lucky, I guess. But, you know, I tell people, hey, you better be changing that toothbrush, your toothpaste every 3 months, because that bacteria can accumulate on that toothbrush. My brother's a dentist, so I know what I'm talking about, okay? And then people don't understand this, but they've just, hey, you got relatives you love and they want to come by your house and they're not vaccinated. You open up your window, I don't care how cold it is out there, and talk to them, but do not let them breathe in your house with respiratory droplets. So, and they may be your daughter, they may be your son, okay? Get Skype or something like that, but we need to survive just these next couple of months, but do not let any relative, any friend, and you need to ask, because they're sure not gonna tell you that they're not vaccinated before letting them come into your house.
Dr. Kane, in our last few minutes, tell us about.
Did y'all talk about the mask? Y'all already talked about
that's what
that,
I'm gonna
right?
ask you now. Let's talk about masks.
Hey, you wanna live? You need that KN95 or N95 mask. KN95 or N95 mask. And if you've got chemotherapy or transplant or HIV infected, those higher risk, they better be wearing an N95. But you need the KN95s, and listen, there's some scams out there. So you really have to kind of check to make sure you're not getting the fake China KN95 masks that they're putting out there. And by the way, there's some fake home kits too. for COVID-19.
So what's the
Cloth mask
difference?
does nothing. Cloth mask does nothing for you. It's better than nothing, but it's got an efficacy probably about 20%. Is that good enough when everybody around you's infected? And hey, we're going to see a deficit in these KN95 masks pretty soon, and the prices are going to go up like crazy because everybody's going to be trying to get their hands on it. I'm trying to get my hands on it.
And what
And
about
so
face shield?
get it early, or you're going to be in the same boat like the home kids.
I see a lot of people wearing face shields. What's your evaluation of those?
Oh my God, their face shields. I don't know that. I think they're worse than the they worse than the cloth mask. Remember now, face shield only just means that bacteria is not smacking against that mask, but there's nothing under that face shield that prevents that air and those respiratory droplets to getting into your nose or in your throat. So they are the lowest of low in terms of protection of face shield.
Well, I certainly appreciate you joining us. Are there any questions in the chat, Dr. Neighbor Stevens or Walks? Or
Tell Dr. Clark tell Dr. Clark, Michelle, I need some mental health consultation, okay? It's amazing the number of people who have vaccine hesitancy, but it is killing our African Americans who are in these hospitals. African Americans 3 times their white counterparts. Who's in our hospitals? 90% of them are unvaccinated. Those are the ones who are dying, unvaccinated.
Dr.
So-
Clark
so
wants to know
Dr.
when we need to get revaccinated while you're talking to her.
What's the question now?
When do you get revaccinated?
So technically right now, they're only having the recommendations for the booster. They have not yet. And I think enough time has not gone around in terms of when you get your annual vaccination for the coronavirus. And I think the problem is we're already starting to see new mutations happen. And so the Omicron may not be the last one that's happening. We're going to see there's new changes coming out of France and other countries. So we got to hurry up and get a significantly higher rate of vaccination to protect our communities.
And
this
also,
isn't
Dr.
new
Kane,
now. We're going to always have to have a vaccine related to coronavirus every year, like the flu.
and Dr. Kane, can you please emphasize that there's no guarantee that the next variant will be less dangerous. It can go the other way.
I think it could really be more dangerous. Exactly right. Because these viruses, they like to adapt, and they're just getting smarter and smarter. It's just it's the level of sophistication related to these viruses is just unheard of. And we got to remember, hey, we had Ebola, and that was a hemorrhagic. I mean, you're bleeding when you contracted that particular virus. And so we've just been very fortunate in our country, but we are here now. We're going to start having more resistant, deadly pathogens coming across us in this 20th century.
So we've got two new questions. One is about whether or not the KF94 mask is something that we should consider. I just want to make the point that on the CDC website, they do have list of the recommended mask, United States, the N95s, the KN95s from China, and the Korean versions, and how to tell which ones are good and which ones are not. And they give the model numbers and everything. So
give that website, Barbara. Give that website.
I'll put it in the chat.
CDC.com.
I'll put it in the chat.
Oh, thank you. The other question is about how concerned we should be about long-term effects of Omicron, specifically Omicron.
So we don't know yet enough. Enough time hasn't gone by for us to see the long-term effects of the Omicron. We've seen the effects from the alpha, and that was just the mildest variant that we first experienced. And look at this, wow, you got the brain fog, people for months, their memory is shot, their ability to do calculation, even 80% of the folks who have this brain fog cannot function and carry out their regular job. And this is going on for a month. It's almost like you say, wow, that person looks like they're acting like they got dementia, early dementia related to this brain fog that people are experiencing. Some folks, they've lost their ability to even walk. You know, they're in occupational physical therapy to teach them how to walk again. But I think it's those folks with the chronic fatigue syndrome. You are so tired, so exhausted. It's a chore to just make it from your bedroom to your bathroom, to use the bathroom. And you don't have no good moments. Like, you know, a lot of HIV patients, when they're first infected or for a while and they're not treated, they'll have a burst of energy for a couple hours and then they'll be really tired, you know, other hours of the day. But the chronic fatigue syndrome folks, they are tired all the time. And they don't have the ability to carry on their normal job. Now, you know, a lot of them folks will lose their hair. So you got a little vanity issue. You've lost your hair. And then of course the folks who lose their taste and smell. And that's dangerous because you can't smell a fire in your house. You literally can't smell it. You could probably get away with loss of taste. But boy, it'd be hard for me to, as I get older, I have a better appreciation of food now. But it impacts every different organ of the body, the long haulers. It could get chronic kidney failure, inflammation of the heart, myocarditis, you know, even as in young adults. So, but we have no clue now. We're going to have to wait a while to see what we're going to see as a long hauler from Omicron.
What do you think is going to happen with the, you talked about it earlier, but I kind of want to push it. Dr. Maxey is back. So just very quickly, the rationing of the Paxlovid, the only effective monoclonal antibody, which happens to be oral. How do you think this is going to play out since the supply is not even, the first of it is really just coming out this month, but they're honestly, I think for a change, saying it'll be June before they really have it up to production level that's needed. How do you think this is going to play out?
It's going to play out that for the vulnerable folks won't get the same access to the supplies as say some prominent person that's got money and have connections and they can get that monoclonal antibody. I'm just telling you, for the month of January, we're told we're only going to have enough doses for 1,000 people, okay? And we're experiencing over 10,000 new cases a day in Indiana. So how do you ration the 1,000? What criteria do you set up for who gets that particular monoclonal antibody? That's the same with the medications you're going to have with Pfizer and Merck. You know, the production is not there. So how do you ration that out? And we're going to be heavily at high risk, all of our vulnerable patients. And so here's what can happen. Well, you know, we need to reserve this for the patient that's most likely going to be successful. So anybody's got a chronic medical condition, we're not going to give them, they don't get this. We can't give it to everybody. So let's give it to the one we think is most likely to survive. So guess who that means, right? It ain't us.
What can we do about that? What can we do? We being
it's tough because it's tough. I've had a major argument with our hospital systems and the ethics committee because they make these decisions. But if you look at most of the ethics committee from all of these hospitals, you don't see people of color on those ethics committees. So if you're not there, who brings that perspective to them like I have highlighted? And so you're telling me that a 65-year-old white male who may not have any chronic medical conditions will get this, as opposed to a 25-year-old Black female who may be single. She's got 3 children, but guess what? She's got diabetes and hypertension. So the white male who's 65 will get the treatment when you're trying to ration compared to the Black female. So we're already at the start of the gate. We're already handicapped. And so we have to really start articulating, making this say, hey, we got to level this playing field because you're already writing us off, and it is not fair.
Dr. Maxey, you're on mute, sir. And now you turned your camera off. You really don't want to talk to us. There you go.
I was saying, Dr. Kane, it's been absolutely wonderful having you on as our special guest. We're at that hour. I want Dr. Neighbor-Stevens and Dr. Hines. And then lastly, Dr. Walks has a final word. Dr. Neighbor.
But hey, I always have to say hello to my Ace Coon buddies who used to keep me out of trouble, and that's Jesse Sherrod and Wendy Green and Michelle Clark. So those 3, I see you guys good company in terms of who's on this call. And
so
of course,
they've all reformed and kept you out of trouble.
yes, because they're the ones who got into trouble. They've always saved me. But my colleague out there, Wilbert, we collaborate on a lot of things. So thanks as well.
Very good. Dr. Neighbor-Stevens?
You know, the more things change, the more they stay the same. We need to use common sense. When you look at these government people on TV and they all got 2 masks on, doesn't that say something to you?
Yes, I really think so. And if you don't have the ability to pay for a N95 mask, then consider a surgical mask with a cloth mask. You can combine both and use it if you're able to tolerate it. But right now, we just gotta. We know in New York City and in the Northeast that already those cases have started to plateau, and in some places even a decline. And it just occurs, these cases start in different geographical parts of the country, and it just hit us later than New York. So it is dropping dramatically, just like we saw in South Africa and United Kingdom. So I think it's going to happen here as well. But the problem is, at what loss that could have been avoided just for being safe for a couple of months.
Well, thank you so much. Dr. Hines?
Thank you, Dr. Kane, for your presentation and just your real world approach and style. I really appreciate it. And then I just thought that this was you brought some very real examples of how people who are waiting to use these backup plans, who are waiting to use these other options as their main plan, there are logistical challenges. So the real thing is, like we were talking, like you said, get vaccinated, do the first thing, like do that. And this was a really good discussion. So
I'm telling you, every single person, once they're in that hospital and they're telling them, hey, I'm going to have to put you on the respirator, you can't survive, they are asking for that vaccine, but they're too late. But if you can, demand the monoclonal antibodies, because we also have the reverse discrimination when they have the products and it is available and they choose not to give it to us, arguing, and then we're past that criteria where you can use the product. So it's unfortunate, but that does continue to happen.
Well, thank you again. Dr. Walks.
So thank you, Dr. Kane, for for just being you. And it's always a pleasure and an honor to get information from you. I wanted to shift our gears just a little bit. This is the time that we celebrate the Reverend Dr. Martin Luther King's birthday. And Reverend Pointer put in the chat earlier that he had some technical problems and wasn't going to be able to stay on with us. And that's okay, because Reverend Pointer brings so much to what we do, because we know how important it is to look outside of just the doctors and the healthcare people for input and for advice. In church this morning, our pastor talked a lot about Dr. King and about the scholarship of Dr. King, about the intelligence of Dr. King, not just the motivational speaking of Dr. King, but just the academic superiority of Dr. King with his education and doctorate and all of those other kinds of things. And then our pastor gave a quote from Dr. King that I hadn't heard before. I've heard a lot of the I have a dream parts and what have you, but I wanted to share this quote for us this weekend as we really go after the things that we need to do, as we look at the fact that, this is just my little personal opinion first, the folks who fought for voting rights, and we're all concerned now about voting rights, I don't know that they were fighting so that we wouldn't have to do anything to vote. I think they were fighting so we could vote. And so if people make it harder for us to vote, we need to still go vote anyway. If we have to stand in line to vote while we're trying to change the rules, we got to go stand in line to vote. So I think that it's important for us to recognize that all of the efforts that went into the rights that we have and the privileges we have aren't necessarily there for everything to be easy for us, but for sometimes for us to have an opportunity to go and do things even though they may be hard. So let me go to this quote from Dr. King that just kind of moved me and stuck with me today. And here it is. We are now faced with the fact that tomorrow is today. We are confronted with the fierce urgency of now. In this unfolding conundrum of life and history, there is such a thing as being too late. This is no time for apathy or complacency. This is a time for vigorous and positive action. Reverend Dr. Martin Luther King, Jr. That's what I got today, Dr. Maxey.
Thank you, Reverend Dr. Walks. That was profound. I thank everybody for joining us today. I want to remind people of Mr. Herb Darcy is going to put in the chat, I hope,
He did.
Okay, the Active Pure machine, and I am literally endorsing that, not only because the Black Health Trust has a relationship with them, but I have two. Dr. Walks was kind enough to deliver one to my daughter yesterday. He has three. Mr. Brooks has number. That these help clear your air and can help protect you. So use every possible mechanism you can to stay away from this Omicron. We thank Dr. Virginia Kane, a major league specialist in infectious disease. And a lot of infectious disease people that I've met are stilted and don't communicate, but she, along with Dr. Jordan, are down to earth and real and communicate well. And we thank
I'm going to shock you,
participation.
I'm going to shock you, Dr. Maxey. Both Dr. Jordan and myself are from Arkansas.
Oh, really? Is there
Yes, so
something
once
genetic?
you-
Is there
so
something
once you meet-
genetic in Arkansas?
So once you meet someone from Arkansas, you're never the same again. That's all I got to say.
Well, thank you. And I thank Dr. Steiner for his input.
Yes.
And Dr. Walks, Dr. Hines, and Dr. Neighbor Stevens. Thank everybody. And Dr. Pointer is not with us. Ms. Ager is not with us today. But in remembrance of them, we like to say thank the Almighty God for protecting us now
Amen.
and going forward. Amen, and have a good day.
Amen.